So we have another guest for our Q&A. This is Jess.
Hi.
Say hi. What are you?
I am an RN/RCIS.
Good. And she's just going to answer some questions that I have, but if you have questions for her, please drop them below because you guys ask a lot of questions about being a tech and a nurse, being both, traveling as one or the other. So we're going to run through some of those, but if you have specific questions for her, just put them below. She is also a part of the Don't Miss a Beat team. She is a contributor in a lot of my books, but I also ask her a lot of other questions. And fun fact, she came up with a business name. I cannot take credit for that. So, Jess,
Yes.
altogether, you've tried traveling.
Yes.
You've been a tech, you've been a nurse, travel for both. You've been full-time and you've been part-time. So we're going to run through kind of the pros and cons of each of those first. But all together, because you play both roles, I'll say, where you work now, do you prefer one over the other?
You know, I've gotten this question quite often, even at work. And the answer is yes and no. Go figure. Honestly, it's never black and white. Truly, for me, it just depends on the case. And it's mostly like the case. And a lot of the time, I prefer to be a nurse because you're always on the go, go, go.
Yeah.
Whereas at the table, I do kind of have like a little reprieve there. But there's something about being a circulator for most of the cases that you're just kind of all over the place. Whereas peripheral cases as a circulator, a lot of the time for us, the reps are there. So you don't really do much. So you're kind of bored.
Yeah. And that's what I was going to ask. Is there like a particular case you like being a nurse and a particular type of case you like being a tech, if you had to choose?
So I guess for peripheral cases, for me to actually do some stuff, I prefer to scrub it. Although there will be days, you know, we're super slammed, super busy. You kind of want a little break. You're going to be a little lazy type thing. You're like, yeah, I'm a circulator in this peripheral case. Like, thank goodness my calves are screaming type thing.
Yeah.
But yeah, when it comes to cardiac cases, I do enjoy doing both, especially since, you know, you never know when a patient's going to, you know, go downhill. At the table or as a circulator, they're both very important roles, and it's just a different kind of mayhem. But for me, I don't know. There's something about running around like a chicken with my head cut off, trying to do this, that, and the third. That kind of, it's the adrenaline.
So if in a STEMI, if we both came in and I'm like, do you want to circulate or scrub? You're choosing circulating probably.
I don't really have a preference per se. I really don't.
You're like, I'm good at everything.
Not necessarily I'm good at everything. It's just I don't really have a preference. And you know, like I said, the doctors as well kind of play a role into that.
Well, that's true.
Because if it's a STEMI with a certain doctor, you're going to be like, ooh, this is going to be good, right? Like, this could turn crazy. Whereas other times you're just like, yeah, you can scrub that case. It's fine. Like, you need the practice. I'd rather circulate or something like that. But in all honesty, I don't really have a preference. I have been circulating for the past 5 years, I want to say, so I'm kind of used to it. So it just all depends how I feel.
I mean, I think it's good that you don't hate one or the other and you don't love one or the other. Like, because there are people who choose to, well, depending where you work and what those roles look like, choose to be a nurse because they don't like scrubbing.
Correct.
They choose to be a scrub because they don't like to push medication. So I think actually enjoying all aspects of the job is good, and you can tap into each of those depending what's going on. If you're like, oh, I haven't seen this in a while, like, can I scrub this? Pros and cons for traveling for you personally, because when you traveled, you were both.
I was both, yes. So I got hired on as a RN traveling. However, the 2 locations that I went to, the first one, if they were short staff or, you know, if it was a very slow day, I'm like, hey, can I scrub? And be like, sure thing, no worries. The other site, it was rotating. So everyone circulated, everyone scrubbed, everyone monitored. However, I refused to monitor only because I'm only going to be there for 13 weeks.
Oh, yeah.
And also, their monitoring system was so archaic compared to other systems. I was like, there's no way I can learn how to monitor in 13 weeks. I'm like, you know what, it's okay. And there was like this pregnant girl there. I was like, just stay monitoring. It's fine.
That works
I
out.
would rather circulate and scrub all day for the next 13 weeks than trying to learn how to figure out your system. Pros and cons of traveling. I would say a pro is money.
Yeah.
I know that so a lot of people go traveling for money purposes. At that point, mine wasn't necessarily money. Mine was more like I've always wanted to travel, see different locations, see different hospital sites. The money was kind of like a plus type thing. But definitely pro is the money. Second, you're only there for 8, 13 weeks depending on the contract. So if there are issues within the department, between staff, between management, between doctors, you're there for a short term. You say, you know, deuces, and you leave. You go to the next location. Another pro is a different location. Obviously, it's kind of like a little vacation.
Yeah.
So if you go to a location you've never been to, it's kind of nice. One of the cons, depending on the site, I know that if you go to a location, you will get worked because you're a traveler for a reason, right? They're short-staffed, and they could be missing 1 traveler, or they can be missing 3 to 4 travelers. So depending on the site, you will be working all day, every day. You will get your lunch break, you will get your breaks, but it is challenging. And there's also different modalities that they do compared to the sites that you have been to, and different drugs as well. If you do the circulating part, different drugs that I've never. I know, I'm sorry.
You can't apologize to the truck driver.
Welcome to my life. Different drugs that you'll have to learn, and just different like cath lab things that are done differently. So
it didn't even occur to me that you're right. The preferred drugs by physicians will be different. So you know what it is and you know when it's used, but you're like, I've actually never mixed this before. I've actually never had to do this.
Correct.
And then if you're a traveler, did the 2 places you went to have a preference, like a medication book of some kind? Because if you're a traveler and let's say you're the only nurse, who are you going to ask?
Correct. So a lot of times, there will be a resource person there. For instance, the first location that I went to, they had 2 nurses, and they were very particular about where the nurse stood in the case. So if you were on one side of the room, the other nurse had to be on the other side of the room.
Why?
I wish
did the patient fall or something?
I don't know, but it was a 2 nurse, 2 tech room.
Yeah.
So if you were a nurse on one side of the room, you would deal with the equipment on that side of the room.
Oh,
and if you're on the other side of the room, you deal with equipment and drugs on that side of the room.
I mean, I see that being efficient, but I also see that being a luxury.
But I remembered one time I went to go like step over the imaginary line just to go get something, and the nurse was like, "No, you stay on your side." And I was like, you're currently doing something right now, and I'm not. I'm trying to assist you here.
Right.
So I was just like, okay, it's fine. Like, it's not my hospital. It's not my
so
cath lab.
interesting.
I wasn't really like annoyed. I was just more perplexed.
Right. And what if they collapse and be like, sorry, I can't help you?
Yeah, I can't cross this imaginary line. Oh no, it was just very different. It was my first rotation too, so I was like, I have to do everything that they tell me to do because I'm new.
Yeah.
You know, it's my first rotation. I don't know anything. Yeah. And also that rotation, I learned how to. They gave Integralin, which over where I work, they don't give Integralin.
Yeah.
So I remember they taught me how to do Integralin, and I ended up messing up. So you're supposed to wait like 10 minutes after the first dose to give Integralin, and your girl gave like the bolus, and then literally like 2 minutes later gave
like
the rest of it.
Yeah,
I gave like right afterwards. So the nurse had told me, oh, you know, give the second round of Integralin, and I'm just like,
already done.
What do you mean? Like, yeah. I was like, what do you mean? I already did that. And she goes, no, you're supposed to wait 10 minutes until you give
like protamine. That's interesting.
Yeah, so I was like, oh crap. And she's like, that's okay. We'll tell the doctor. It's fine. To own up to your mistakes.
Yeah.
And I guess for me, I didn't ask either, but at the same time, no, I guess they kind of assumed I knew how to do Integralin as well. So, you know, you own up to your mistakes and you tell the doctor, you know, I kind of messed up. So luckily for him, he was very nice about it. And he was like, that's okay, it's fine. We'll just watch the patient for, you know, bleeding complications or whatever the case may be.
Yeah.
So I'm like, okay. But once you make a mistake like that, you know, for the next round,
I will never do that again.
You'll never do it again.
Or you'll ask, is there any special way I'm supposed to give this?
Is there a book I can use? Is there something? So there is that. It's okay. The patient didn't die.
Yeah, I mean, and this is how I feel. I see a lot of these posts in the Facebook groups. It is so incredibly unrealistic for you to have an expectation, traveler or not, physician or not, that one person knows absolutely everything.
Correct.
Or they've done it. That doesn't mean they know it 100%. Yeah. What if you've always given Integralin, you've never waited, and you were like, yeah, I can do this, and then you do it and you didn't wait. And they're like, I thought you said you know how to do this. You only know what someone has been nice enough to teach you.
Correct.
What if they just didn't correct you? And they just went, yeah, sure, whatever. And then you go to the next place and you do that. And then they're like, hold on, you're supposed to wait 10 minutes. And you're like,
never done that in my life.
Didn't know that.
Exactly.
But we all learn together. I think it's important to be patient. Pros and cons of being a tech. So for context, that's how you started.
Yes.
You didn't start as a nurse. You started tech for...
I became a tech, went to nursing school 2 years afterwards.
Really?
Yeah. So we graduated.
How long was the program?
5 semesters. So just under 2 years.
Wow, it feels so recent, but I guess it's not. Well, yeah, if you traveled for 2 assignments and then you've been there for a couple, that maths.
The maths, yes. I was scrub tech
Wow.
for 2 years, went into nursing school. However, I mean, I still was working in nursing school, so technically 4 years as a scrub tech before I became
that makes more sense
a
to
nurse.
Me. Right, but started the program within 2 years of employment.
Correct.
That I accept.
Okay,
I accept that timeline.
Yeah. Thank you.
You're welcome.
So, yes, became a nurse in 2020, just before the whole COVID rush, and then just been here ever since.
And we will circle back to the program and the format and that choice. So pros and cons of being a tech for you and your experience.
Pros and cons of being a RCIS in general, not necessarily in...
Both that and the role. Because obviously there's a reason you chose nursing, but there's a reason you also still choose to... You could have said, I don't want to be... In my job, I don't want to do the tech role anymore. I only want to do the nursing role. So obviously there's a give and take of situations where you like it, job employment wise and job security wise. I know there's reasons you chose other things, so that could be the cons. But yeah, pros, both like everyday job, because obviously there's still some part of you that likes that role.
The pros of the job itself, like in the lab, and as to why I continue to do it, is just to keep me on my toes. And to understand from a tech's point of view and a nurse's point of view type thing. Because when I was a tech, there's a lot of nurse stuff that I did not understand, right?
Yeah.
Why is this given at a certain time? Or why is this done at a certain time? So I guess a pro of that is being a scrub tech / RN is when I'm at the table, if I see that the nurse is busy or not necessarily paying attention to the case, I can kind of hint to them or just kind of double check their work. Yeah. Hey, was the heparin given? Hey, was this given? Was the equipment gathered? And that type of stuff. So you can kind of like a safety blanket for the circulator if they're not a experienced circulator. I guess that's a
perspective.
Pro. Yeah, that's a pro for myself and for the circulator, because at the end of the day, it's patient safety. So we want to make sure that everyone's doing their job and everyone's paying attention. Con of being a tech is that I don't want to say that you will be used and abused type thing, but you will be
and it's
wanted.
Location specific.
Mm-hmm.
I will say, we didn't discuss, you work at a very, very high volume place. Correct. In my opinion, it's a very high volume place. There's 5 dedicated cath labs that also do, in my opinion, high volume vascular in all of the labs. A hybrid lab that's shared with EP, and EP is completely separate with their own 5 or 6 labs, 5 labs, 4 labs, and then the hybrid. So your staff is 30 to 40 people.
I want to say 35-ish, 40 now.
Yeah, which is a lot. Go ahead, continue. Used and abused.
So used and abused, I don't like saying abused, but you will be used. When I first started, there were only 1-2 other nurses that scrubbed as well. Yeah. So for instance, if there's a scrub tech on vacation or a couple scrub techs on vacation and there are more nurses on staff, you are going to be in place of that scrub tech.
Yeah.
Which, you know, for sometimes it's like, okay, awesome. Yeah, I get to do both of the things. But I remember literally this past year, we were short techs, which I just find baffling because it seems like there's so many names on that list. And you're just like, how are we short staffed on techs?
Scheduling wise,
correct.
It comes up short.
Correct, because we do have the hybrid lab,
right.
that 6th room that needs to be filled in. There was a long time, I want to say probably 3 to 4 months, where I was just scrubbing. They had me as a scrub tech. I think I was a nurse every 6-week schedule period. I was a nurse maybe once or twice in that. Oh yeah, girl.
Wow.
I was a nurse probably once or twice.
Well, I guess both ways around you lose skill though. So there's you want balance. It's just not realistically.
Correct.
Always an
You know, I want on and off type thing, not consecutive as scrub tech, because then on those days, that random day that someone called out, for instance, a nurse called out and they pulled me out into being a circulator, I'm like, my speed has significantly decreased, you know?
But their expectation is still
correct.
here.
I'm like, oh, but you should still know. Yeah, but I haven't circulated in like 2 months.
Yeah.
3 months, you know? Yeah, I might know what to do, but my flow has been disrupted.
Yeah.
So that's essentially a con of being a tech for me, is that I will be pulled ever which way. I will be a scrub tech, and then when we have to relieve at 5 o'clock, I'm relieving a nurse. So then I'm a nurse for the rest of the day. Or I gotta relieve over in TAVRs, you know, or I gotta relieve, or I gotta be charged. You know, they pull me into charge after 5 o'clock. So you're everywhere.
Yeah.
And it's nice to be wanted, but not always.
Yeah. Well, and I have people reach out to me who are like that, and you're somebody, when you were hired, you want to learn everything.
Yes.
And you don't want to say no to anything. But when you're at a place that does so much, it does hurt you to be that person who knows how to do everything. Because if you say no, you're the problem.
Correct.
If you said, you know what, I haven't nursed in like 2 months, I'm not comfortable just getting pulled into this bipellet case all of a sudden. Then they're like, well, that's why you're here. I get it. It like benefits you outside of there in your opportunity, but sometimes it hurts you when the lab has become too comfortable with everything that they can use you for.
Because it's the same people.
Yeah.
It's the same people that want to learn, that want to do everything. And then when it's time for those that should know how to do their stuff, they don't do it because they don't feel comfortable or they haven't done it in a while. But it's like, okay, but I haven't either. Yeah. It's like, I haven't either, but because I have more experience, it means I know how to do it or I know how to remember. Right. Honestly, there are days where I'm just like, I don't remember how to do this. Yeah. Like, I will let you know right now, rotablator, I can't.
Yeah.
They will tell me however many times how to do rotablator, and a week will
There's
go
no
by.
room.
A week will go by, and I'm just like, how do I do this rotablator again? Like, it is my arch nemesis.
Yeah.
I'm
That's
sorry.
how I feel about balloon pump. It's so, I know it's so simple, but I need someone to double check me. I'm like, this wire is for this, right?
Yeah, exactly. That's why
we all have that.
And at the end of the day, you just got to rely on your doctor, and hopefully, you know, it's a doctor that knows what they're doing, right? And they're comfortable in doing what they're doing. So a lot of times I'll be like, you're gonna have to tell me what to do. I will give you it. I will be ready, but you know, there are a couple steps that I'm missing here, and I just can't remember. I'm sorry.
Yeah.
The storage is full.
When you have someone who can do all of these things, they don't have the capacity to remember in detail absolutely everything. So yeah, you can pull them in there, but they're gonna be, you might have more experience being in situations where you don't know everything and you have to take instruction. That's a skill that you've developed. But you and someone else have the same level of knowledge. You just have experience in being voluntold and being put in uncomfortable situations to have to take direction. Other than that, there is no difference between you and the new person who hasn't done it.
Correct.
If the new person's capable of taking instruction, congratulations, you get to scrub.
Exactly.
What's the difference?
Go learn.
Yeah, what's the difference? And they're not going to get that skill if they keep pulling you to go in there. They're never going to develop that skill of being uncomfortable, because even, how many years in are you?
Almost 9.
9 years later, tomorrow you'll still be put in a situation, you're like, I've never done this. But they're like, but you caught it. You've been here. You're like, but I have no experience in this situation. Why am I so important? My paycheck doesn't say that. My paycheck
Facts.
doesn't say I'm the most important person here, most valuable person here.
Yeah, that is
I think
true.
we get paid the same. If you could do it again, would you have gone to the floor or stayed in the lab after getting your license?
Okay. I'm actually kind of glad you asked this because I was literally thinking about this the other day, and I just keep.
You can't change anything.
I can't
but
change it. Right. Exactly.
For other people's advice, if they were in the same situation, would you tell them to stay or would you tell them to go to the floor?
Okay. I would. Two different scenarios, but I guess at the end of the day, definitely go to the floor. And I'm not talking about med-surg PCU because, I know a lot of people are like, med-surg PCU, whatever. And some places it's great and other places it's like horrific, right? And that was honestly the reason why I chose not to go to the floor because I was like, there's no way.
That's all you've really heard.
Exactly.
I guess.
There's no way I'm going to work med-surg or PCU. I've heard awful things about it. I've heard about the patients. I've heard about, and it's just like, it didn't
Ratios
call for me, it was like, it wasn't enticing at all. So I'm like, why? Might as well just stay in the cath lab. No, I know what to do. The only thing I have to learn now is just medication.
Right.
I know about the equipment. I know about the doctors and their flow. I know what to expect. I know what happens when vitals tank, whatever. It's just more of the medication aspect. If I were me back in 2020, granted,
that's a different time.
that's a different time too.
Yeah.
So if COVID did not happen in 2020 and life was peachy, I would have definitely either stayed in the lab for about a year, so then I could at least say I know how to be a cath lab nurse.
Right. That's true because you might not get that opportunity the other way
Correct.
around. Yeah, true.
So I would have said, you know what, let me just stay here for a year or two even, because I do think it takes time to feel comfortable in your role, at least 3 years. Because it took me about 3 years in both, RCIS and the RN role to feel comfortable. So either go to the floor right off the bat and just get experience in different locations, whether it's ER or ICU or decent PCU med surg floor. Definitely get that experience because I feel like, yes, I know cath lab and I know everything about cath lab. There's a lot of stuff I don't know how to do if I was ever, randomly floated to a med surg PCU floor.
Well, they can't come to the lab with half of the stuff that they're on and the machines that they're hooked up to and some of the management stuff. It's, you don't see it and that's no fault of your own. There's just, they can't come with it.
Correct. So like blood, for instance, asking for blood, how to order blood, how to even administer blood or plasma or stuff like that. Like I learned in the cath lab because of other nurses that have had floor experience.
Yeah, who are like, you should probably know how to do this.
Yeah, they're like, you should, or they'll, ICU patient will come down from floor with all these drips and all that stuff, and they're like, you're okay with this, right? And you're like, no. I've never had to deal with a propofol drip, a levo drip, and all these crazy, insulin drip or whatever. Now I'm okay. Now I'm comfortable with that stuff. But even then, I still have to rely on the medication book for titration.
Yeah.
Because ICU, they are allowed to titrate. In the cath lab, you have to titrate. I mean, it's a verbal order from the doctor. Increase your epi, decrease your epi. You got to do that. Or if the doctor is comfortable enough with you and you are comfortable enough with the medication, you could do it yourself. Let the doctor know, hey, blood pressure's up or the MAP is low, whatever. I'm going to bump up this medication or I'm going to decrease this medication. I am finally at a point where I'm just like, okay, I can do this. However, if I have an ICU nurse in my room helping me out, whether I'm on call or it's a STEMI, go touch that pump. And a lot of the times those nurses will go to the pump and just start titrating or whatever. And I'm like, you go.
And then teach me after.
Yeah, you do that. I will worry about the equipment. I will start the code if I have to. But the pump, teach me afterwards.
How can you know? And I am curious if you ever go work on the floor, how that's received and how you communicate that. Because, I mean, you see it when the cath lab hires people from ICU or ER, understand the other side of all the other things going on, why you couldn't manage the drips in the way that you could, why you couldn't set it up in a way that was organized for when you do then drop off the patient, because there's all these other things that we're doing. If they understand your lack of experience in that.
Correct.
Versus having this expectation of, well, you guys do all of this stuff. Yeah, but it's completely a different kind of nursing. It's a procedural nursing, which is not the same. And you could have seen it, done it, doesn't mean you're proficient enough to feel comfortable doing it without preceptorship or without somebody verifying for you. So I'm curious how that will go, because I think it's quite rare for your situation, first of all, because I see a lot of labs kick out their nurses after they get their license and say, you have to go get experience in ICU, CCU, blah, 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 or we won't take you back after that, which is wild. Because it's hard to find a cath lab nurse in general. Don't kick them out. But even if you tell them once a week you're going to go to ICU to go help or shadow or whatever, so you can learn that, that's a good way to retain them, but give them the experience. I'm curious, why have you ever asked about that?
So interestingly enough, when I became a nurse, I mean, they furloughed people.
Yeah, that's true. COVID.
They furloughed people. They were short staffed for most of the part. So, and we weren't getting cases, right? So even if they wanted to send me to ICU, COVID, you're increasing my exposure, right? You're increasing those exposure, which, if you wanted to do that, great. But I understand that during COVID, the nurses there were very stressed, very overworked.
Not a time to teach.
They're not a great time to teach, and I do not blame them at all. However, I do, if I'm not mistaken, when another tech in the department became a nurse, or just nurses without ICU experience started working in the cath lab, they started to send them to CCU once or twice, maybe 3 times during their orientation, just so they are familiar with the devices that we use or the drips that we use, because they only have med-surg PCU experience, not ICU.
So in nursing school, you don't go to any of those places, or do you?
So
I don't know. That's what I'm asking.
I'm trying to remember. I recall, so most of the time I was in some kind of PCU, floor progressive, so neuro progressive, neuro step down or cardiac step down. Then we would do our L&D, 1 day in NICU, stuff like that.
They're not invested in.
Correct. I don't recall ever going to a critical care floor or even a trauma floor. If I got it.
See, but I also wonder, did they look at you and go, she has critical care experience?
So the thing is, we don't. We do what
but
we
people
don't.
don't know that. But a nursing professor probably doesn't understand that if they haven't been in the cath lab. To them, that's as critical as it gets. So they're like, you should know how to do all this stuff.
Yeah, and I don't. And that's the thing. We are a procedural area, and we're expected to do these cases with patients that are critically ill. And a lot of the time, the nurses can't stay. They're short staff on the floor, right? So they essentially just drop off their patient and head back. And now you're left with all these drips, all these devices that like, you don't know how it freaking works. WinVac's drains, which whatever. WinVac put at the end of the table on the floor and it does its job. But, just all these drips, and we're expected to learn how to titrate and do all this stuff. We do all this stuff with these critically ill patients, plus do our job, but we're not considered critical care.
Right. I had someone come with an insulin pump, like whatever they're actually called.
Yeah. Insulin pump.
Okay.
Yeah.
Well, there's like
like
insulin in a pump and an insulin pump.
Yeah,
I had to Google it. I was like, can this be in radiation? I don't know. What is this? People come with life vests.
Yeah.
I don't know what to do with
this. Do you take it off? Exactly. And that's unfortunately, it's just trial and error. You learn, you ask questions. And a lot of the times, the patients know more than other coworkers or even yourself. Because I'll be like, oh, this, and they'll be like, yeah, I can remove it for you. And it's like, please.
Can you do that? Is that okay?
Yeah.
Do I need to give you something?
Your sugar's not going to drop or whatever. We're not going to know, right? You know your signs and symptoms, right? Or just the life vest. Now I know that the life vest has to come off.
Yeah.
Pump has to be, either removed or covered by the lead shield or whatever the case may be. But a lot of times the patients will tell you.
Go to the floor or negotiate that in your orientation, because I'm sure places that have techs transition to nursing isn't common, and they don't know what to do with them. Do I just throw you in because you know what you're doing? Do you just need 2 weeks to learn the circulator role, or do we need some sort of formal thing like that where you get these different exposures? Because I as a leadership wouldn't want to lose you completely. And then what if you love it there more and you don't come back?
Exactly.
You know, then you've lost them forever. Would you currently be exploring other nursing role options outside the cath lab if they had given you that exposure in orientation?
Just knowing me and my personality, I'd probably say yes.
Okay.
Only because I like learning and I love seeing different things, working on different things. It's so weird because I consider myself, I work better alone.
Yeah.
Like I can only rely on myself. I'm hitting the microphone, sorry.
That's
I
okay.
can only rely on myself to do the job type thing, which is funny because I've been in the cath lab for 9 years and that is a team-based job.
But you still have a role to play and you have to do that role to the maximum of your ability. So it's still you versus you, just with a team, which is,
Yeah.
it seems counterintuitive, but it actually works.
Yeah, so part of me is like, I would love to go try the floor because of those things and just to say that I did it. And also, and it sounds silly, like I want to learn how to do wound care. I want to know how to put in a Foley or straight cath a patient, because the only time I ever did that was during clinicals, and it was one time years ago. There was a travel nurse that we had to put a Foley in after a STEMI, and I was like, I assisted her with it, but I didn't do it. She ended up doing it. And literally just a few weekends ago, one of the doctors asked the patient to be straight cathed, and interestingly enough, the two people in the room were scrub techs turned into RNs. We were like, oh, I don't know. I don't know what I'm doing.
We gotta go get charged.
Exactly. We have to, well, interestingly enough, the person in charge in cath lab had ICU experience, so she knew how to straight cath. So she ended up teaching us how to straight cath, and we were just there all watching. And we were just like, oh, so that's how you're doing that. And she was helping explain and everything, but it's just stuff like that. You're like, in my head, I know what needs to be done, but I don't know. Exactly. I don't know. The last time I straight cath the patient was in clinicals. Yeah. So that was 6 years ago.
Yeah. And you almost feel like, I shouldn't be doing this independently by myself for the first time with nobody to verify if I'm doing it correctly.
Correct.
Because I wouldn't know. I'd be like, yeah, that looks good. Hold on, let me look it up. Okay,
Exactly.
now you do this. Now you do this.
Yeah. So, and it sounds awful, and that's what I'm saying. Like just stuff like that, straight cathing or certain medications or even getting like IVs. I enjoy.
You don't do it every day.
You don't do it every day, but I enjoy getting them when I get to because it's the practice. Granted, can I go to the pre-post area and try to stick a few people? Sure, I can. I probably should. But
add that on the list.
But there's something about like a patient comes in with a blown IV and I'm just like, okay, like here's my job. And most of the time I get it, but I know my limits. Yeah. And if I can't get it out or I'm gonna hurt the patient, I'll be like, let me go get some experienced nurse that I know.
I tried.
I know she can get it or he can get this IV better than me.
Yeah.
But it's just stuff like that,
Yeah.
I wish I had more experience on or even stuff with blood draws.
Yeah. But it'd be the same the other way around. If any other nurse in any other place, I don't know about the OR, but came over, they wouldn't know 90% of the nursing role in the lab. So it's the same is they're going to see tons of medications they've never given. They're going to see, I'm sorry, I measure the thing on the IVIS. Yeah. Why? That's not something you do bedside. So there's a lot that that doesn't necessarily apply other places, minus like Impella. You would be so confident with that bedside. And I can tell you from experience, that's the number one thing that majority of CCU, CVRR, ICU nurses are uncomfortable with. And you'd be like, I'm good. All this other stuff.
That is so interesting.
I don't know. Yeah, well, but they don't put it in. Yeah. They don't see how it goes in, where it sits, haven't experienced complications, aren't part of the resolution for the complications when it goes back to the lab. It's just like a magic thing and then it appears. You're like, this is inside the body, don't really know how it got there, and I'm supposed to manage it. I would be uncomfortable too. I understand. So, But they don't know that if they haven't got hired onto the lab and realized there's a whole other role of nursing that they haven't experienced. So I'm sure you going there, they would have this expectation. You'd have to be like, do you want to come with me to the lab for a day and see what it's like, so you know what I know, and then you can teach me all of this other stuff?
Yeah, I think that's one of the biggest like things I fear the most. There's, so many times I'm like, let me go to the floor. Let me just, take a break from the cath lab, stay PRN, go to the floor, see other things. And it's a fear of starting new, essentially.
Yeah.
Even though
you've done it like 4 times now, but.
But it's like, I'm so confident in my job in the cath lab. Like, that is all I know. So to start on the floor, something new, is starting from scratch, and it's almost kind of like scary.
Yeah.
And it's like, oh my gosh, like, I don't want to start new.
You're going to go from knowing everything to knowing nothing.
And knowing nothing. And that is frightening. Do you know? At least for me, I'm just like, oh, but I know so much cath lab. But at the same time, I'm not going to grow.
Yeah.
If I don't learn how other floors work or what they do or what's expected, even like I said, the drugs, the drips.
Just have to find, well, at least you work in a hospital and you do know from dropping off patients and interacting with them how happy other departments are, who their leadership is, who their main people are that would probably be your preceptor. And that's a good way to say, I can tell they're willing to teach. It might not be the exact floor you want to work in, but they'll teach you some of those basic nursing skills that you just don't use. And they're not going to have, shame you for not knowing that. Like,
well, hopefully they don't, right?
Right. You hope.
Yeah. So.
But you can kind of vet them beforehand because you get to see them outside of an interview. You talk to them all the time, and you can kind of tell, like, because you see them when someone's practicing, like giving you a report in the lab with their little nursing preceptee, how they react to them, how they teach them. That's how they would treat you, probably.
Yeah, that's true.
So be like, you know what, they seem kind. Or when they come up to you and go, my preceptee's hopeless, you're like, all right, crossing you off my list.
Exactly.
Go find a different department. And I'm so glad that you have a mix of people who came from ER, CCU, that are willing to teach you. And not just be like, yeah, I got it, I'll do it. Right. They can be like, here, let me show you how to do this so you know how to do it if you ever need to. Because that's a good way to get that preceptorship even though you're not on the floor. What's your advice on both learning how to take constructive criticism and giving it? Whichever one you want to start with.
Oh, God. How to take constructive criticism is take it personal, but don't take it personal, if that makes sense.
No.
Okay.
Embellish.
Yes, I will explain further. Take constructive criticism and be like, hey, I noticed, let's say, nurse to tech, tech to nurse, nurse to nurse, whatever the scenario may be.
You can use
me. Okay.
Shame me.
I'm not going to shame you.
Yeah. What did I do wrong?
But it's like, hey, I noticed that you were unsure of the temp-pacer insertion or temp-pacer, how to, cover it up. Just know that if this is not done properly or you don't secure it well, it could come out, especially if the patient doesn't have an underlying rhythm. It is something very important, like this patient could essentially die. And by don't take it personal and be like, oh, okay, I acknowledge that something was wrong. Take it personal, like, dang,
Take ownership.
Take ownership. I guess that's a
like
better.
Like care.
Yeah, exactly. Like, dang, I could have harmed this patient. Let me be better. Or let me ask questions on how I can be better. Let me see someone do it or see their opinion or how they do it so I can be better. I've realized over the years, a lot of people, when you tell them something, granted, I will say there are certain people when they deliver constructive criticism,
it comes how to give it, part 2.
Yeah, it comes off a little rough. However, I try to be like, hey, yeah, you could have killed this patient, or hey, this could have went
well, you don't
wrong,
want to sugarcoat it because then it's not going to seem serious.
Correct.
And then you want the person to take it well, but not take it so lax that you're like, do you not care? Because there is a balance on both sides, on caring enough to take the feedback and apply it, and delivering it in a way that matches the seriousness of the situation. Like, going back to you crossing the imaginary nursing line in the room, it's not going to kill somebody.
Right.
But yeah, you not securing the temp paster well is going to kill somebody. So me treating both of those things with the same level of passion
Right.
isn't going to be received well, because you're like, well, she freaks out about me tying the trash bag wrong, and then she freaks out about me not about me not.
There are people out there.
Well, that's what I'm saying. Yeah. You can be passionate, but it's not. Treat the things that are make or break like make or break, and treat the other things as just a hey, FYI, not like a we need to have a conversation.
Well, I think a lot of it too is, when receiving constructive criticism and giving it, you go through orientation, you're 3 months, 4 months, however long, 3 to 6 months, depending on the hospital system. And there's this expectation of you to know how to do everything. Oh, well, you did this before. Well, why don't you remember how to do it again? Like I said before, it took me almost 3 years to feel comfortable in my position, in both positions. So I think a lot of people forget that they were once new. And it's like, sometimes it frustrates me too, because I'm like, I know you've seen this before. I know you've done it. And one of my biggest
Why
pet
isn't
peeves.
it sticking?
Yeah, one of my biggest pet peeves is I don't know what I'm doing. I've never done it before. Confusing it with I've seen it be done. I've done it a few times. I don't remember.
Yes.
There's a difference between I've never done it before and I don't remember how to do it.
Yeah.
Because when I know you have done it, you were with me, I showed it to you, and you tell someone else and that gets back to me, oh, I've never done it before. Like, that's infuriating.
Yeah.
It's
But
like,
also other people are going to blame your preceptor.
Correct.
And be like, did you not teach them how to do this?
yes.
Versus them admitting, I've seen it and I don't remember. I've seen it and I keep doing road later. Yes, I know I've done this a bunch of times. I still need you to walk me through it because I want to get it right, because I care. But I am self-aware enough to know I'm not competent in this.
Yes.
And that's on me. I get that. But I need your help.
Yeah, and that's why a lot of people, like I said, they expect to be, after 3 months, they know how to do everything. Ownership. And like you said, ownership. Own up to it. I don't know, or I don't recall how to do this. Or yes, I've seen it before, but it doesn't click. Please walk me through it. And then the other person receiving it, don't get mad about it.
Yeah.
Don't
At least they were honest with you.
Yeah, exactly. Don't get mad about it. Be like, well, you should know how to do this. You've been here for X amount of time, this, that, and the third. That, and I get it from a preceptee perspective, or someone that just came off orientation. They're like, I'm never going to talk to that person.
Right.
I can't rely on that
I'm never going
person.
to ask for help again.
Correct.
I'm just going to pretend that I know how to do it when I don't. That's what you're teaching them.
So back to the original question, because I told you, derail.
No, I'm derailing with you.
How to take constructive criticism, and hopefully the person that gives it to you is doing it, constructively and not overly passionate, if we want to say that. Just literally sit there and be like, what did I do wrong? And how can I be better? And take ownership.
Yeah.
Because if you genuinely could have killed the patient, or you forgot to give a medication during a procedure and the patient's clotting off, you forgot to give the heparin, you forgot to do the angiomax drip, you forgot, whatever the case may be, own up to it.
Yeah.
Yes, that other person, whether it's a staff member, a doctor, they may get mad and they're heated at the moment. That is one, that is not for you to fight back.
It's not the time.
That is not the time for you to fight back and argue with said individual. Own up to it. Be like, oh my gosh, yes, I will give it right now, whatever. Then have a separate conversation with that person outside and be like, one, thank you for letting me know, or whatever. Or the other conversation would be like, I did not appreciate you talking to me like that. If I did something wrong, I totally understand. But it could have been explained to me or told to me in a different manner. Or in a one-to-one conversation, not in front of everyone.
Right. You want to acknowledge, I understand why you're upset. I did mess up. For someone who doesn't deliver it the right way, or is just, it isn't constructive. It isn't criticism or feedback. It's just taking out their anger on you. I understand why you're upset. This is important. I did mess up. However, please next time deliver it in this way. Or our time to just tell me how to fix it. And then if we need to have further conversation about it, We'll talk about it after. But you getting upset with me does not fix the problem for the patient in the moment, which is what I needed. What we all needed
Yes.
to move forward from this. Anecdote. First one, I was just tired. You and I used to be call hogs, and I really stopped doing it after this. So it was with a physician who is known to explode. And I don't know, I honestly wasn't paying attention, and I was just going through the motions. We took forever. AS patient, aortic stenosis patient, to cross the valve. We crossed the valve. Immediately, I just pulled the catheter out.
Oof.
I don't know why. I was meant to, walk. It was a Amplatz with a straight wire. I was meant to walk it out, whatever. I just pulled everything out. He was like, okay, come out. And I just didn't use critical thinking and just took everything out. And he looked at me and he was like, you're an idiot. I was like, yep. I am. I said,
oh my God.
And I just looked at him. I said, I apologize. I have no idea why I just did that. I know that's a big deal. Let's try and cross again. Do you want to give heparin? Because it had been like 2 minutes at that point. We crossed over, but he, every time then, when we went in with just a pigtail, he's like, you're not going to pull it, right? And I'm like, no. But he knew. I'm grateful he did not blow up on me because that's his nature. But he could see in my face, I knew what I did wrong. I just owned up to it and then offered a solution. And then, yeah, he did berate me for it afterwards, but in like a joking way, but he knew,
Yes.
I knew I screwed up. Then the other time, I was not tired. It was just miscommunication. This was a physician in a different hospital who trusted nobody. Double checked everything, and I was working so hard to get him to trust me because I loved working with him, and he was so progressive. And right heart cath, brachial, changed out for the PICC line for the sheath, all that. Was going to get a TAVR. It was a TAVR workup, and had the balloon in to float up. Was coming back. You have to deflate the balloon to remove the swan, and I did. I did not know, amongst everything else that I was doing, that he had reinflated it at some point and then took, I don't know why he did this, locked it, removed the syringe, pulled negative, and reattached it. So when you look at it, if you didn't look at the lock, it looks deflated. And the last I knew, I had deflated it.
Correct.
So he looked at me and he said, is the balloon down? I just confidently said, yes. And he goes to pull it. But this should not normally happen, but complete heart block, got stuck in the sheath, obviously, because it's not going to come out with the balloon inflated, which is when he knew the balloon was not deflated, and looked at me, and I looked at him, and I looked at the screen, and I was like, temp pacer, please, and put in temp pacer, blah, blah, blah. We just didn't speak and solve the issue. I did what I needed to do. Patient went out of the room. I went in the bathroom and cried. I was so upset, and he was like, okay, this patient's a TAVR workup. She needs a permanent pacemaker before we do the TAVR. And in my mind, I'm like, I just put that patient in complete heart block. And we had 6 more cases with him after that. And I was like, I cannot continue the rest of the day like nothing happened. And I know I can tell he doesn't want to talk about it, but I need to talk about it. Or I'm going to question everything I do the rest of the day. So I pulled him aside in the monitoring room and I sat down and I just apologized. I was like, I am so sorry. I said, I know you have a hard time trusting people, and you didn't double check me, and I just gave you every reason to double check me from here on out and not trust me, and I want you to, because I've never done minus that pigtail incident. I usually do not do things like this. I was almost in tears. I was like, I'm so sorry. I understand what I've done to that patient, et cetera, et cetera. And he just looked at me, he said, I can't make you feel any worse than you feel right now. And he was like, and the fact that you're upset is why I trust you. And he said, we all make mistakes. I've made mistakes. It's unfortunate that it caused patient harm. And look, I'm going to cry now.
No, don't cry.
And he was like, but you never know. Maybe if she's that sensitive, we were going to do the TAVR and she was going to go into complete heart block on the table. So now she'll have a pacemaker before and it'll be fine. You can come see her TAVR if you want. I was like, okay. And we moved. I mean, that was over 6 years ago.
Right. And
I'm still upset about it. But for me, handling those situations like that, because I do feel it so much, and I'm way, and a majority of you, if you understand what you did and the harm it could have caused, you're going to be more upset with yourself than they could be with you. And you can use that. I've used that line before. you can't make me feel any worse than I already feel. Thank you.
Mm-hmm.
I leave when they're like arguing with you.
Correct.
You know, explain it, talk about it, take ownership, and that's how you build trust. You just build
Correct.
trust by being honest. And if he had screamed at me in the moment, that's doing absolutely nothing, and that's why he didn't. It does nothing to contribute to the case or the solution. He could tell immediately, I knew what I did and I screwed up. But that patient's awake, first of all. For a majority of these procedures, they're awake. And they're going to hear you if you're arguing over something, especially a mistake.
Yep.
They're listening. Would I like to go back and not have any of those things happen? Yeah, but I handled it the best way that I could in the moment. And that's the end of that. And if he lost a little trust, and he was kicking himself for not double checking me, and that's why he was upset.
Right.
The outcome wasn't great, but he could see that was probably better for the patient in the future. He was kicking him, and that's what he told me. He's like, I was more upset because I let myself trust somebody, you know, but because I didn't double check you, and I should have. And also, he knows he's the one who inflated the balloon, but that's besides the point. I wasn't there to blame him and be like, well, you did this, and I just said, I'm sorry, I thought it was deflated. Why am I going to make you realize it's your fault? Again, doesn't contribute to anything. And then we moved on.
And that's, in my opinion, how it should be done. Because, like I said, I've realized there's a lot of people that do not know how to take constructive criticism, and they just take it personal. Like, oh, this person, doesn't like me. They're always doing this to me. Like, they're always attacking me type thing. And I don't know about you, but if someone were to tell me, hey, you did something wrong or you almost killed a patient, I would have been like,
thank you.
Oh my gosh. Like, I would be like you. I would be crying. I'd be like, oh my God, I could have killed this patient. And that's why it's just kind of interesting to see, what I've noticed in the past few years of the different type of people that have entered the Cath lab is I don't know what it is. In my opinion, the way I see it, it's like they don't take the job seriously. They
don't realize it is life and death.
They don't.
Everything goes great, but it is life and death.
Correct. Like, do you know what to do when things go south? Do you know the signs and symptoms of what to look at? Or do you know when you look at the freaking x-ray, dissection, why the doctor's freaking out? Can you see the dissection? Can you see the massive perf? Can you see the patient slowly start to get hypotensive? Like, are you noticing that? Are you just,
Or
you're
just tra-la-la-la-la.
Exactly, you're tra-la-la-la-la-la-la-ing.
Well, and I think the difference, say OR and Cath lab, the patient is awake, so you cannot, a physician cannot verbally freak out and say, oh my God, guys, we have a perf, we need da-da-da. The patient is going to hear the tone, even if they don't understand the words, and the panic. And that, like, there's so much of a patient's calmness and mindset and not thrashing on the table and all of that leads to better outcomes, even in a complication, that I know as a new person, you hope someone points it out to you. And honestly, as the constructive feedback in the moment, there's a way to point it out and say, hey, that's dissection, serious complication, you need to do da-da-da-da. That is not the time to shout at them for not knowing what's going on. You can after and say, hey, did you realize like that was serious? And if you do not take it seriously, if you do think it's just
another job
of it can be a fun job, but if you can't get into that mindset in those almost complications or complications, then it might not be for you.
I agree.
Because it isn't fun and games. It can be when you want it to be, and then when it's serious, you need to be able to flip that switch. And if you're just always like that, and fun and games with no accountability and no care for making mistakes or no care of trying to get better, there's so many other things that you can go do that you're probably great at. It's not this. And I don't want to force you to be somebody who you're not or you do not want to be. And I used to have this conversation with students. It's okay. No one's forcing you to be here. It's okay if this is not for you. And it's not that you don't have any value. This just is not catering to who you are. And everybody else who does really care is not going to understand, and I can't fix that. I can't change you into this person if you do not want to be this person. So that's my 2 cents. I hate saying people don't belong in the lab, but there's every job in the world, and there's some that are not for you. There's some that are not for me. What do you do if that's your preceptee? What is the conversation you have? If you try to give it to them and you see they literally just don't care.
There have been times where I've had conversations with other people, nurses and or techs, where you have to sit with them. And I think a lot of people don't do this because they're uncomfortable confronting people. Because,
it's not going to be a comfortable conversation.
They're going to talk about me behind my back. Oh, they're going to take me to leadership. Oh, they don't, the whole, they don't like me type thing. This is a job. And like you said, it's life and death. You need people that are going to care about the job. And maybe I just care too much about my job.
Same. Well, there's a reason I don't work in the lab anymore. That's one of them.
I care too much about my job, and I expect others to give more than average. That's just me. But you have to have the conversation. So if it was my preceptee and I saw that, they're on their phone constantly, or they're not writing stuff down, or they're not asking questions, or they don't want to learn more, sit with them. Be like, hey, I have noticed said things. I do not think that's going to work in the lab. If you really want to work in the lab, those qualities that you have aren't going to work well in the lab for you. Now, if you really want to work here, I suggest XYZ, or, doing this instead of this in the lab. Still, I'm not going to be like, these qualities are subpar, you don't belong here type thing. First of all, give them a chance. I'm all up for giving people a chance.
Maybe nobody's ever told them that before, that being on your phone makes it look like you're disinterested. You not writing things down, like when your waiter doesn't write down your order, makes me feel like you weren't paying attention, or you don't actually care about getting it right. Maybe literally nobody's ever told them that.
And I just find it interesting because Cath Lab is a lot. Cath Lab is a completely different monster. And
new language, new motor skills.
Yes.
It's like driving a manual car in a different country on the other side of the road, where all of the signs are in a different language.
Yes.
That's what it is.
I love that comparison. But it's like, you're telling me that you're not writing down what each medication is for. You're not writing down doctor preferences. You're not writing down equipment and what they're for. You're not writing down terminology and what it stands for and what it means. That's a different story for a different day. So I would have that conversation. Hey, these qualities that I have noticed, it's not going to fly here. I'm sorry. You might see it with other people. And if you really want to work here, as a preceptor, I want you to do good. And it's not because I want you to make me look good. Right?
I want you to enjoy doing this.
Yes, because I know I am doing the best that I can do to make you the best. And a lot of it does, like you said, a lot of it does come with the person. Like, luckily, the person I precepted she's great. Like, she had IC experience. She had grit. She had willingness to learn. She was hands-on. Like, I remember her second day in orientation, we had an AS case, and the patient...
Aortic stenosis.
Yes, sorry. Aortic stenosis case, patient came in totally fine, and she coded, and she died on the table. Her second day. And all I did was hand her the epi, and she slammed the epi because she was comfortable. If it was anyone else from the floor, or even the grad nurse, or probably anyone else, a lot of people, they're going to freak out. They don't know what to do. They've never been in a coded situation, or, they're just scared. And that's completely normal. They don't know their place. It's completely normal. However, if you can follow instructions,
I think that's literally the
follow
best
in a code. Just
Yeah.
follow instruction. You don't even know what's going on. I don't care that you don't know what's going on, but I need you to push this epi. I need you to flush this line. I need you to give all these drugs.
Yep.
I'm not asking you for you to do anything else. If you can do that, beautiful.
You don't have to know what everybody else is doing. I really think being able to follow instruction is a huge skill. Because a lot of the times, even devices you don't know, a rep is there and their job is to give you the step-by instructions to do it. All you have to do is listen.
Listen.
Hopefully they know what they're doing. But if they do, all you have to do is listen.
Listening is a great one because, like I said, a lot of people are going to be scared and they're going to shy away from it and they're just going to watch.
Yeah.
Watching is not going to help
shut
you.
down.
So they're going to shut down. They're going to step away to the side, whatever. And I feel like if you just, especially during code situations, if you just rip the Band-Aid off from the beginning, the next time you're in a code situation, you know what to do.
Yeah, it's not that bad if you know your strength and what your role is in that situation, and you can do that role. It's not that bad. When you start being like worrying about what everybody else is doing, that's very overwhelming. I don't know. At the end, I'll be like, what all did we give?
Yes, I think at the end of that code, I was like,
that's why there's a recorder.
So what just happened? I think we gave like 11 EPIs. Back to the original question. Yes, have a one-on-one conversation with them. You know, these qualities aren't going to work. Try these qualities instead, and then reevaluate. And if you notice they're still not doing well, then take it to education or leadership. Have that conversation with them. Hey, as your preceptor, I had this conversation with you. I told you these qualities are not going to work. Improve them, do something. But I've noticed that you haven't. You're still stuck there. Leadership, I'm letting you know from a preceptor point of view that this is happening. You do as you may with that information.
We did try to resolve it. We're seeing a pattern of behavior. And at that point, it's a choice.
Yes. And if you are allowing that just because you are short staff or, you know, you just need a body, I don't know what else to say.
You're telling everybody else that it's okay.
Exactly. I don't know what else to say. Then, you know, you have all these questions about why the cath lab is being ran a certain way or why certain people are doing certain things. And you are allowing it.
Yeah. Versus if you have a really understaffed lab, for you guys, let's say you had 50% of the staff and we're running half of the labs, but they might not all be super skilled, but they all care and are trying to do a good job and have good communication. That staff is not going to be as burnt out as a fully staffed cath lab with half of them with poor work ethic, everything's personal, everything's an attack kind of environment. Then your other 50% are going to leave, and you're stuck with the 50% that you trained to be that way. Because that's what you're doing. When you aren't having those meetings with them, when there's no repercussions for their actions, you are training them to be that type of cath lab stuff. It isn't a desk job. It isn't a retail job. There are places you can be like that, and this isn't one of them. Or if you hate emergencies, and that's the other thing, doesn't mean the cath lab isn't for you. Maybe that lab isn't for you. That level of acuity, that case mix is not for you. Maybe you will like outpatient where things are slower, nothing's an emergency, everything's scheduled. You only have, 3 cases that you're going to do. You know those patients. Maybe that's for you. You only work with 2 physicians who always do the same thing the same way every time. You have to know your own limits. And I get a lot of people like that who say, oh, I hate change. I like consistency. A multimodality, high volume cath lab is going against everything of who you are as a person. Unless you want to change to be that person, that's great. And you're like, I want to, like the nursing thing, I want to learn these skills and experience these different environments. But then you have to be a sponge and apply that feedback. And if you don't, and you don't want change, and you don't want to learn anything new, cool. Identify when a lab isn't like that. They don't function that way. And they're not going to cater to what you like. And you can't only do these cases. You can't only work with this physician. We have 60 physicians. You can't only work with this one. It doesn't work that way.
Mic drop.
Circling back to nursing school. You were full-time in the lab?
Yes.
Okay. So how was balancing nursing school and working full-time plus call?
I don't know. It's all a blur. Now that I think about it, I don't know how I did it.
What did the week, why I know because we share a Google Calendar, what your week looked like, but what did your week look like?
In nursing school, working full-time, taking call, going to school full-time, trying to manage a relationship, it was a lot. So I would work 4 days a week. I would, on the days that I have school, depending on the semester, typically school was 3 to 4 times a week. at night.
Yeah, you did not do a accelerated or part-time program.
Correct.
You
I did not.
Just the traditional full-time program.
Traditional 5 semesters. So school was 3 to 4 times a week, depending on the semester.
In the evening.
So in the evening, yes. So I would work 6:30 to 5. Literally, quickly change into my school uniform. Go drive down the freaking interstate to go to school on, and it was like 15 minutes, whatever. Barely make it to class. I felt awful. I think class started at like 5:15. So.
Oh wow.
I know.
4:53. Clocking out.
Exactly. Not like I was changed, ready to go before 4:53. Clocked out, and I was like down to the garage, and it was awful. But I did it for 5 semesters. So I do that, and then class would end at 10:30. For me to do it all over again the next day. Wake up at 5 to go to work at 6:30, go to school again, 10 o'clock, take call. Yeah. So if I was scheduled call during those days, I'd have to ask someone, hey, can you cover my call from this time until 11 p.m.? And then I will take the rest of my call back from 11 p.m. to...
Heaven forbid you get called in.
Yeah, and it has happened before. And luckily, I will say, I had a lot of team members willing to help me because they knew, she's working full-time, going to school full-time, she wants to be a nurse, she's going to be an asset to our department. Yeah. I'm willing to help her. Even the weekends, our clinicals were on the weekends. I'm still, the scheduler is still going to schedule me my call weekend. It's my responsibility to find someone to cover me. So I'd find someone, be like, hey, I have clinicals on Saturday or Sunday. Can you please cover me from 5 to...
You didn't get the whole thing covered, just the segments.
Just the day that I had clinical, exactly. And I told him, I will pick up call literally right after clinical. And it was, it would be exhausting, grueling day at clinical, and I still had to take my call. And there were days that I get called in. I just had to deal with it. Towards the end of my program, so last semester was practicum. I had to do 8 shifts of practicum. Yeah. I remember because the schedule for work already came out when my practicum started. So I couldn't be like, hey, I can't work this day because I have to do practicum.
You're beyond requesting off.
Exactly. So I had to figure it out. So what did I have to do? I remember, like I said, if I were to do it now, I couldn't. I don't know how I did it. Practicums were at night. That's the only time you're going to ever catch me do a night shift, unless it's a STEMI. If it's not a STEMI, you're never catching me do a night shift. Work during the day, get off at 5. I would eat. I would change into my school uniform, my school uniform. Go to, luckily it was the same hospital I worked at, just on the floor, whatever. Go up to the floor at 6:30 p.m., work overnight my 12-hour practicum shift. And sometimes there were days that I'd have to work again the next day.
That's crazy.
I can't, no, you're never going to catch me do it again. I'm sorry. I had to do that for 8 days. And, they give you the whole semester to do it was divided into 2. So like practicum A, practicum B. So if you're in practicum A, you had like 2 months to finish. And then practicum B, you had the last 2 months of your semester to finish. And I think I had like the second half of the semester to finish. I had 8 shifts. And so, you had, 6 weeks to finish. I said, no, ma'am, I'm not going to be doing this for 6 weeks.
Oh, God.
So I sucked it up. I would do like 2 shifts a week, 2 to 3 shifts a week. I think I was done. Yeah, I think I was done in 2.5 weeks with my practicum. It was grueling. It was awful.
What do they say? Short-term suffering for long-term gain?
That's exactly what it was. And luckily, I was like, I'm just going to do this for 2.5 weeks. But it was a really long 2.5 weeks. I was cranky. I'd go to work cranky from the lack of sleep. I remember this one time I think it was like my 3rd day in a row. I hadn't slept in a very long time. And I had to go back that night to do my night shift. And the scheduler was like, do you need tomorrow off? She's like, we don't need you tomorrow if you really... Because I was like, I am exhausted.
Yeah.
I don't know how I'm even functioning right
You're
now.
You're going to pull out the pigtail out of the LB.
Yeah, exactly. And, we're in the cath lab. That's this patient's life on the hand, and you're having someone that's sleep deprived. Granted, it is my fault. I put myself in that situation. But when she said I did not have to come in tomorrow because we have enough staff members, I was like, blessed be. I get to sleep for more than, 4 or 5 hours. This is amazing. Granted, I had to go to clinical that night, but rather get it over with, suffer for a little bit just to get everything out the way.
I mean, I don't blame you, because it doesn't, whether you have 1 or 3, it's hard. And it's whether it's hard for 2 weeks or hard for 2 months, 2.5 months.
5 semesters. 5 semesters. And then the days I had break is I would obviously, work, not have to worry about school, but I was working, I was picking up call, because I felt bad. That was me. I felt bad that all these people were taking my call some days of holidays or winter breaks, summer breaks.
You just took it.
I just picked up call and all that stuff, because that's me now.
Guilt tripping.
Mm-hmm.
I know you're at different stages of your life, but comparing these two things, ignore the fact that you were working.
Okay.
What was harder, the AS CVT program or the nursing program? Learning wise. Not every program's different, but I will say our program was hard. That's why I asked.
Our program was challenging, very challenging. And I barely made it some semesters, I barely made that 77% that I needed. I did. There was one semester, pathophysiology, that class, I was on the brink of failing. I don't know why I couldn't understand pathophysiology, but here I was.
I think that's why I asked, because nursing school's like that, where I feel like it's a lot of information about a lot of different things that don't really connect.
Correct. So, interestingly enough, I would say, I think I've told someone this before, for me, the nursing program was a lot harder. Because it's not, ours is so niche. It's cardiac mostly. And then I think we started to maybe trickle into peripheral and more structural and stuff like that. Thank goodness. It's not us now doing that.
Yeah.
It's more concentrated, just cardiac, respiratory, peripheral stuff. Nursing is everything. Yeah. Your mom and baby, pediatrics, baby, a cardiac, GI system, neuro, all these meds, all these diseases, the disease processes as well. Like, you had to learn. So then, of course, it comes to the cardiac people.
It's like patho for every class.
It's like patho for every semester was patho. I was over
You're like, I've been through this trauma once.
The only time I was happy for was check-offs.
Oh, yeah.
Check-offs. That was the only time I was happy. I was still nervous to fail it and all that stuff, but I was like, this is simple compared to what I'm freaking learning, So that's why, and so when it came to the cardiac portion of our class, of course, people knew I was a CVT. Like, oh, you got this cardiac. And then even the professor would ask me questions. And in my head, I'm like, I only know Cath lab. Like, I don't know cardiac as a whole.
Invasive cardiology, not general cardiology.
Exactly. Yeah. So it's just like, I only know so much. So then, of course, they're expecting you to get A's. Oh, she works in the Cath lab. She knows everything about cardiac. I don't know anything about drugs. I only know some stuff about drugs, like the radial cocktail.
And we have a book, and I look it up.
Exactly. But like drips, like cortisone drips, and all this stuff. And I'm like, I don't know what these beta blockers be doing, these calcium channel blockers. I don't know all about all that stuff. So I think I got like a B in that class because it was just all about the systems, and it's just so much to learn. So much to learn.
On this much energy.
So much to learn, working full time, and then taking the test, and then you only had one more time to take the test, and then you had a dosage calculation exam every single time, and then if you failed it, you had to take it again. If you failed it the second time, game over. Game over.
Like wipeout.
And you want to know how often I do drug calculations? 0.
By hand?
By hand?
0.
I am so annoyed. So annoyed.
New Cath lab nurse tips.
New Cath lab nurse tips.
Let's say new grad, because a lot of places are hiring new grads.
Yes. New grad nursing tips.
Top 3.
Always, always, always put yourself in every case, if that makes sense.
Get involved.
Get involved. Hands-on. Even if you do not know what you're doing at the moment, do it. Please do not, granted, and this is all depending on your preceptor, because I know some preceptors are like, you're not touching anything until I know you can do this. Yeah. To each their own. Get involved as much as you can. You don't know how to set up the patient, start touching the patient. Put the cuff on, put the stat on, put everything that you can. Eventually you'll get your groove. You don't know how to open a catheter? Start learning how to open catheters. You don't know how to, just touch everything, learn how to do everything as much as you can. Because I'm letting you know right now, personally me, if it's your first week, first month, and I still see you sitting in the corner, not really moving much or whatever the case may be, we're gonna have a problem.
Number 2.
We're gonna have a problem. I'm gonna have words with your preceptor.
Yeah.
2, take everything with a grain of salt. You know,
It's not personal.
do not take it personal. Do not. You will not learn if you keep taking things personal, because then everything's gonna be an attack.
Yeah.
And you know what? Believe it or not,
It's exhausting.
it is exhausting, but a lot of the time, especially if you're new, yeah, you are the problem. You know?
Yeah.
You did do something wrong.
Yeah, you're
Whether
right.
it could cause patient harm or not.
Yeah. And you're going to mess up a lot, so then
You
it's going
are.
to seem like a lot, but you don't know. And you're not going to know if you don't let somebody tell you.
You're not, exactly. And just take ownership when you do that. And like I said, I've been here almost 9 years, and there's still some things. I'd like to think I know everything, but I know I don't.
Yeah.
You know,
I always tell everybody there's not enough room in your brain for all of that.
there's not, and there's always something new that we're adding to the cath lab, whether it's equipment or medication or workflow wise, or even like documenting things. Like, there's always something new, so you have to be,
Get over it.
yeah, you do. Because I know that I've done some stuff recently that's like, you know, so I get it, but you have to take ownership. Once you're off orientation, or you've been there for a year, 2 years, whatever it can be, just take ownership.
Number 3.
3,
Lower your expectation of yourself.
that's a good, and others, honestly.
Yeah.
So lower your, it's going to sound bad, lower your expectation of yourself and others. And I guess for yourself, it can, you're like, well, why should I do that? I'm trying to be the best that I can be. I get
Have
it,
grace.
100%.
Yeah.
Because I was like that too. I need to be good. I need these people to know that I'm competent.
Yeah.
You know? I don't want these people to think that I'm trash, that I don't know what I'm doing. Like, this is my job. And you know, I started off young.
Yeah.
You know, I was in my early 20s when I started this career, and I was working with a lot of people well into their 30s and their 40s, even their 50s and 60s, you know? I didn't want these people to think that
This young girl can't handle it. She
this
can't
young
hang.
girl's lazy, she don't want to learn. So I was in there all the time.
In there like swimwear. I don't know who says that. I think that's
And
the
they're
song.
like swimwear. Yeah, I think someone does too. But at the same time, I would beat myself up constantly if I did something wrong, and it would get to me
Yeah.
physically, emotionally, mentally. I did not know how to let it roll off my shoulder.
Yeah.
Type
Like
thing.
like care, address it, and then you have another case. So be ready again. Like it's going to be constant, like getting slapped in the face and falling on your face, and you can't let it last all day.
Yeah, it put me in a mood. Exactly.
Yeah.
You have to let it roll off your shoulder, because something bad would happen, or the doctor would yell at me. I would hold on to that for the
Okay.
whole entire day. So it was affecting my mood. It was affecting the patient. It was affecting team members.
And the physician forgot about it by the time they
Yeah,
scrubbed out.
exactly. Because I just did not know how to just let it go.
Yeah.
Also, with other team members, lower your expectations. Because I think halfway through my career, I expected so much from my coworkers
I had
that
a hard
it
time with
was pissing me off, and I was just in a foul mood all the time.
Yeah.
Because it's like, I'm putting 100% into my
Why
work.
aren't you putting 100%?
Why aren't you putting 100%?
Or that is their 100%, but I'm
Correct.
not
And
acknowledging
they're
that.
being praised for it just as much as I'm being praised for it. Why is that a thing?
Yeah.
Nowadays, like, when someone does something and people start talking about it, of course, I'm just like, I'm not surprised. Like, I'm not surprised anymore.
Yeah.
You know, because if I were to care as much as I did earlier in my career,
Like these people, I mean, you have good friends at work, but we were friends before we worked together. They're not the people I'm coming home to every day. So does it really matter? I wanted the best for the patient, and that was always, it was never personal. It's like, I just want the best for the patient. Why didn't you catch this? Why don't you care that you didn't catch this? And at the end of the day, I can't make them care more. If they're going to choose pushing the patient out of pre-post because the physician's ready and we didn't do any labs and we didn't do a pregnancy test and they're 25 years old, I can't make them care. It's my job to catch it and then do something about it, but thinking differently of them isn't a value added for me. It just makes me frustrated. They're with no change. So all I'm doing is getting upset and then carrying that with me and then feeling some type of way about them. And I'm like, I don't know what goes on in there. Maybe that's their 100% and I just can't move on from it.
It's not worth it.
No.
It's not worth your mental health, your emotional health. And that, like I said, it took me a very long time for me to realize that.
Yeah.
So.
Well, it's hard. You're not used to working with all these different types of people. And this is why I say I can never be a physician. And I know that about myself. They rely on so many people to do their job. How? I don't know how you do that. If they didn't tell me about an allergy or didn't do this, like I have 300 patients. How can I know everything about this patient? And people have certain expectations of physicians too, and don't realize what their day-to-day is, and they don't know some people make an effort like to look up a little bit about the patient and pertinent things of why are we here. I think that's important. You should know that before your case. You put them on the schedule.
Agree.
At least look up why we're here.
A lot of the time it's their PAs or their MPs. Yep. And
what can techs do to better help a circulator during a case? I would have liked to know this.
As a nurse,
because not all circulators are nurses.
Not all circulators.
So scrub. How can a scrub make the circulator's life better?
Okay. So there's a twofer for this one. Definitely help set up the patient. I think a lot of people, when they monitor, they get zoned in on the monitoring, like, oh, everything has to be at this exact same time, boom, 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 for legality purposes. Yes, to an extent, right? Please do not tell me you're going to sit at the monitor and put patient in room, wait for the patient to either move themselves or be moved, patient moved, wait until, like, stuff like that. Be proactive, go in there, help real quick, quickly go back to the monitor, do what you got to do. Go back into the room, help put the patient on the monitor, help remove the stretcher out of the room, help offer your scrub tech to open the tray, right? If they're busy, if it's a radial case, they're setting up for radial, they're doing that. Or you do that for them and tell them, hey, go drop your table, I got this. Just be more helpful towards actually the circulator and the scrub tech. But I'll help set up your patient. You go pull meds if you haven't pulled meds yet. Or, yeah, I realized we didn't have this equipment. Let me go grab it real quick. So, or if it's going to be a PCI, let me get some stuff ready for you while you set up the patient. It's just kind of like, it depends on the facility because some facilities are a 3-man team versus a 4-man team.
Yeah.
Legally, a nurse or a circulator should not be leaving the room.
Whoever pushed the sedation.
Correct.
Yeah.
They should not be leaving the room. We know that. However, that's not always a perfect world. I expect my monitor person to help get up and get some equipment. I understand the monitor has a job as well, looking at, documentation and looking at vitals. However, as a circulator, I'm in the room. I can look at vitals while you go grab something because I just sedated my patient.
Yeah. I guess if you they shouldn't be leaving the room anyway. There are some circulators who tra-la-la around labs and don't stay in your lab. Then as a monitor, you cannot leave. But yes, if you trust your person to stay there and be like, can you watch the monitor while I go get this stuff?
Yes. And it's all about communication and also delegating. I actually recently told one of the nurses, we had a case turn into a PCI with a doctor that is very go at the table. And I was scrubbed in, and the person at the monitor was just sitting there. And I like to think I know when someone's struggling or needs a little bit of help. So, delegation, but that nurse did not delegate at all.
Was just like, I got everything.
Not even. They're asking for 50 bajillion things. As a monitor person, as a scrub tech looking at my monitor, I can't break scrub, drop my equipment, and then go back in. Like, that's not how that works. Get up real quick. Yeah. Put on your lead, drop whatever I need, go back to monitoring, or go grab the equipment that's needed, like the balloons or the stents or whatever, crossing catheter that the doctor might need, go get it and give it to your circulator. And I had a conversation with that nurse at the end of the case I'm like, hey, just this is neither here or there, you know. However, I do feel like the monitor person should have gotten up to help you a little bit because, you know, 50 million things were being asked for during that time. And she's like, yeah, I can see that. I do not know if that person didn't ask for help because they want to better themselves, right? Because that's kind of like me, be like, nope.
But delegation's hard too.
Don't get it. But at the same time, I don't know if it's a delegation issue because there's a lot of people that won't delegate. Because I know if I'm circulating and there's 50 bajillion things and my monitoring person is just sitting there, get up, go get me this. Yeah. Please. Can you go get the balloon? Can you go get that wire? Can you go get that
And that's
stent?
some people, there are some people who won't just do it themselves. Or
Correct.
I don't know if you as a circulator are going to get angry if I leave the monitor and I'm not paying attention and something happens, if you're just going to blame me. Or if you tell me and give me a command and say, can you go get da-da-da, then we're all agreeing, you're agreeing, I'm leaving, I'm going to go get this, and you're going to pay attention.
Exactly. But that's like communication and delegation just go hand in hand. And a lot of people are afraid to delegate because they feel like they're overstepping. However, in order for the workflow of the procedure to continue, you have to. Remember that someone walking down, they just happen to show up at the right time. You're like, hey, you busy right now? No. Can you get me this? Delegate.
Yeah.
Just do it.
True. And so a lot of managers ask, like, oh, what does staff want from me? How can I be? That is how you do it. Just be a runner. Go get stuff. We're not asking you, relieve me, scrub me out. Just be the float person. Get the patient, bring the patient, help set them up, help go get equipment, bring in equipment.
How to set them up.
Oh, yeah.
Because there's a lot of, not every cath lab manager has cath lab experience. We all know that. And it's really hard to get a cath lab manager with cath lab experience. If you do plan on being there for a year or two to climb up the ladder, please learn the workflow of the department. Okay?
Everybody can do a blood pressure cuff.
Exactly. Don't just manage. Please. You have to be a leader as well.
Contribute.
Learn how to pick up the patients. Learn how to, read the consents, what the consents need to say, if they're appropriate or not, or they need to be fixed. Learn how to set up the patient. Learn what drugs need to be pulled for basic procedure. Learn where the equipment is to go and grab it real quick and then come back. I'm not asking you to do the case for me. I'm not asking you to do anything, watch the patient while they're sedated with case movie because you don't know how to do the case.
Right.
But at least know how a procedure works. And don't just walk the labs just to show face. Like, oh yeah, my manager shows face all the time. But do they help you?
Yeah. And again, you know your limits. I mean, I've had nursing students who were observing, they put lead on, came in the room in the corner, and it was really, really bad code. And my monitor person was busy going and grabbing things and calling people. And I needed to put in a temp pacer and I needed to sheath the wires and whatever. And they're in the cabinet right there. And I was like, girls, can you do me a favor? Just listen to my instructions. Open this third drawer, get this. Okay, now you're going to open it, but don't touch the inside like peeling a banana. Stay still and I'm going to grab it from you. And they handed me all of my stuff. I was like, oh my God, thank you. And they have they were told, go in there, don't talk, don't touch anything. And I was like, thank you for following instructions. Like that made or broke what we could do next, because we could do nothing if we could not get access and put in a temp pacer. And I'm not going to ask my monitor to come in and do it. My circulator's busy because the patient's coding. So it was just, and my only option was scrub and get it. And then I'm wasting time doing that. So if they can do it, manager can do it.
Yes. This is why listening to instructions,
big skill,
is so important. And also don't assume that people know how to open things sterilely.
Yeah.
Because I did that one time during a STEMI. I asked an ER nurse to please put the fluids on my table, and sweet soul, she, instead of, ripping the package, spiking the bag, putting it on the table, I went to go drape my patient. The doctor was scrubbed in, I turned back around and the doctor's looking at the table like, what is this? And the lady literally just tore open the package and literally dropped the bag of hep saline onto my table. And I looked down.
But you can't be mad.
I can't be mad because I assumed she knew how to pour fluids, and that was my fault. And luckily, luckily the doctor took it well. And I was just like, so he just grabbed a towel and like tossed it off the table. And I took a towel and I was like, that did not happen. It's a stubby, you know? Like, what are we going to do? Reopen the whole tray again? No, we're just going to cover it up with a bunch of towels. And luckily by that time the circulator was available and they poured fluids into my bowl. But I was like, I cannot believe.
Thank you for being here today.
Mm-hmm. You're welcome.
Again, if you have any questions for her that we did not answer, because this is probably well over an hour and a half long, put it in the comments, because Jess is a good friend of mine as well, so I do see her all of the time. Thank you so much. If you like this video, please like and make sure that you subscribe to my channel if you want more like this in the future. And if you're starting out in the Cath lab, you are not alone in being totally overwhelmed, and hopefully some of these tips help you, or if you're experienced and learning how to communicate, should give some great advice.